Dr. Mayur MOREKER. He's going to demystify further persisting and relapsing inflammation despite AKT in ocular tuberculosis. I think it's a continuation of this talk. Dr. MOREKER, please.
Good morning, everyone, and greetings from Mumbai. And we are here to talk about persistent and relapsing inflammation despite AKT in ocular tuberculosis. We all know that the diagnosis and management of ocular tuberculosis poses a significant challenge despite the publication of standard treatment workflow from the ICMR. We are sometimes in situations where use of anti-tuberculosis treatment fails to stabilize the inflammation, and there are relapses which require immunomodulatory treatment, which may be conventional or biologics. And that exactly is the aim of the study, with an emphasis on assessing the role of Mantoux test grading and time to intervention with AKT since the diagnosis of ocular inflammation in predicting the requirement of immunomodulatory treatment post-AKT. In a retrospective study, which was initially planned for about a year, but then we extended it to about 3.5 years or more at our institute, where all patients were treated as per standard guidelines published by the ICMR. The Mantoux test was graded as strongly positive if induration was about 20 millimeter, or if there was a blister formation or ulceration accompanying the induration. And the time to intervention with AKT was considered delayed if AKT had been introduced 6 months after the initial diagnosis of ocular inflammation by the primary treating ophthalmologist. This is a summary of the results. The first year we had 34 patients, but when we extended it, we had a total of 103 patients, of which 14 were returned back to the primary institute because they went back to their place of stay, and 89 were the patients who continued their follow-up with our institute. This is the spectrum of involvement of the various organs of the eye. This is a diagnostic workflow sheet. You see that of the 89 patients, 82 had Mantoux test, of which it was positive in 65 patients, and a CECT was done in 78 patients, in which it was positive in 70 patients. This is the treatment summary. You can see that all the patients were treated with AKT, and AKT plus immunomodulatory treatment was included in 28 plus 1 patient who received topical immunomodulators. So we come back here to the summary of the results. We are starting off with 89 patients. Persistent or relapsing inflammation requiring immunomodulation was present in 29 of the 89 patients. It includes the 30 of the 34. So you see it's about 1/3 in 1 year, and it's about 1/3 in 3 years as well. This is the breakup. You see that methotrexate is the most commonly used agent. It is used in combination with other agents as well. And in 2 patients, we had to resort to use of tofacitinib. Calculating the odds of requirement of IMT, when we see Mantoux strongly positive, delayed introduction of AKT, the odds are higher when both of these are present. But when these are combined, you see the results. 30 patients with a strongly positive Mantoux test, 20 of these had an additional delayed intervention with AKT, and 13 of these 20 patients required use of immunomodulatory treatment. Complications of IMT because of AKT, resurgence of tuberculosis not seen in any patients, as is in sync with other literature. Points to ponder: persistent or relapsing inflammation noted at times despite AKT in ocular tuberculosis. Adequate and appropriate use of immunomodulatory therapy resorted to at such times. Strongly positive Mantoux test and delayed intervention with AKT increases the odds of requirement of immunomodulation post-AKT. But probably the most important point to ponder over is that 20 of the 30 patients in this series had a delayed introduction of AKT despite having a strongly positive Mantoux test and despite having additional supportive systemic radiological evidence of tuberculosis. And 13 of these 20 ultimately ended up requiring immunomodulation. And this makes it important to dissipate knowledge of the clinical phenotypes of ocular tuberculosis, which is all important for the diagnosis of ocular tuberculosis. Limitations of the study obviously related to a single center personal bias. There are other factors also. And finally, the conclusion remains the same as the points to ponder. Persistent inflammation may require immunomodulation, which may be considered safe if given under the watchful eyes of primary physicians or chest specialists. Thank you.
Thank you, Mayur. I think it was a very interesting caveat which you brought out. So the patients who received delayed AKT, develop more of, like you're trying to say.
Yeah, are more likely to develop such an inflammation which will require immunomodulation.
So what is your hypothesis for that? Like, why would you say that is happening in these patients?
I think that's related to the fact that then you will have the nidus for the inflammation which will persist for a longer time. If you intervene with AKT early enough, then you are treating the organism
the, yeah.
there.
So
So
there's a
it's something
persistent-
like an infection getting converted into something like an
Chronic,
inflammation.
My question is why it was started delayed when they were already
Yeah,
suspected to be.
yeah, so
suffering from
that's what I'm trying to bring out.
Yeah.
These are all patients which have been referred to our institute. So it's taken time.
Okay.
Patients have received treatment, not got better, then referred to
Okay.
us.
So diagnosis was delayed actually.
Yeah,
By the
yeah,
time
the
they reached
diagnosis
you.
was
Okay.
delayed.
Okay.
Do you think a subset of Do you think there's a subset of these patients which not necessarily will be requiring immunomodulation, but as Madam presented in one of her cases, could be a resistant?
Yeah, so I was waiting for that question to come
Yeah.
from you. So in all these patients, see what the chest physician is doing is you notice all of them have undergone contrast enhanced chest CT. So whenever possible, we do a EBUS, biopsy, and then you have the organism, and then you already
Okay.
have tested for the.
Great.
So we haven't used this in any of those patients who had MDR.
But that will happen only if the patient is having pulmonary cox. What
Yeah.
about the rest areas?
So in the rest areas, then so what we are doing lately is that we are actually recommending a PET CT to screen
Okay.
the entire body and see if there is any other place.
Right.
Very good. Very.